Good evening, everybody, and welcome. Thank you for joining us for today's webinar. My name is Michelle Zepeda, and I am the Program Coordinator at Waterford Place Cancer Resource Center. Waterford Place provides programs and services free of charge for anyone impacted by a cancer diagnosis that supports whole person care. I would like to introduce the speaker for today, Dr. Chen from Rush Copley Medical Center. Dr. Chen is a radiation oncologist who treats patients with all types of cancer and uses stereotactic radiation when possible to minimize treatment times and side effects. Dr. Chen received his advanced training in radiation oncology from Rush University Medical Center. We are so glad to have you here this evening presenting, and I will turn it over to you.
Thank you, Michelle. Thanks for putting this together. Thanks for all that are attending, and thanks to Waterford Place and to Mariana also for putting this together. Today I'll be talking about radiation therapy, or sometimes we call it radiotherapy, in the treatment of breast cancer. As Michelle said, I'm a radiation oncologist. I am a doctor that treats cancer with mainly X-rays. I work with a great team of other doctors to treat breast cancer, including surgeons, medical oncologists, and we are also very fortunate to have a whole huge team of professionals in our cancer center, including nurses, therapists, social workers, nutritionists, and too many people that I can't name all at this point, but we have a great team that we all work together to treat breast cancer and other cancers at the medical center. So today's talk, I will split into three basic sections. First, I will talk about the basics of breast cancer. And then we'll go through the radiation basics as well, sort of how we do it, why we do it, these kinds of things. And then finally, we'll go into some new techniques that we do in the modern era that have improved quality of life, have decreased side effects, and we'll go through things that aren't widely available yet also. So why are we talking about breast cancer? Well, of course, this is Breast Cancer Awareness Month, and we also know that breast cancer will really affect quite a few women in their lifetimes. 1 in 8 women will be afflicted with breast cancer within their lifetime, and this is the most common cancer in women, and it actually has a death rate that is basically second only to lung cancer for women. So chances are you know somebody that either has breast cancer or will get breast cancer in their lifetime. So it's very, very important. Over 270,000 people this year, mainly women, of course, will get breast cancer. So first off, let's roll back a little bit and talk about what cancer actually is. Sometimes it's hard to try to wrap your head around what this disease means and how it sort of happens. So what I like to say is cancer is a family of diseases. It's not one single disease. It's sort of like infections. There's different kinds of infections, but it's a various, there's breast cancer, there's lung cancer, and all these diseases are different. And they do different things, but they share one thing in common, and that is that they are caused by mutations in the DNA of normal body cells. What that means is DNA is the blueprint for each and every building block of your body, which are cells. This is a picture or a cartoon of DNA. It's a windy helix that codes different genes in your body's cells. When those genes go haywire, and are mutated, so let's say one chemical base gets changed into another, bad things can sometimes happen. And so what the genes in cancer that are changed typically are the genes that tell a normal body cell to stop growing. So most of the time, cancers keep on growing and growing and growing and don't stop when they're supposed to. They're also genes that tell cells to stop where they are and not sort of invade into their neighbors, normal cells. And so those genes are sometimes knocked out in cancer as well. And also there are genes that tell the body cells to stay put exactly where they are and not spread all over the place. And those genes can also be knocked out in cancer. Typically in cancers, these genes, multiple genes are knocked out or mutated, I should say. And that's why we get the cancer that either grows and doesn't stop growing or spreads to other places. As I said before, each cancer is different and therefore requires different treatment. Some cancers will actually disappear on their own sometimes because your immune system is able to take care of them. Some cancers don't require treatment. But some cancers, no matter what we do with whatever treatment, they continue to grow. So it's a big spectrum of diseases, and breast cancer is one of these diseases within that spectrum. So because each cancer is different, we treat them differently, sometimes with surgery, sometimes with chemotherapy or other drug treatments. Nowadays, we have targeted therapies. I think my screen's stopped. Are you able to see my screen still?
No, I think I might have minimized.
Let me try this again. Sorry about that.
There we go.
Okay, perfect. So I was talking about the chemotherapy or drug treatments. These days we have many other drug treatments besides chemotherapy, hormonal therapies, immunotherapy, targeted agents. We'll go through that in just a little detail. And then, of course, what I do is radiation therapy, which is treating cancer with X-rays. So I'd like to talk next about the types of breast cancer. There are two main types of breast cancer, and the main type is ductal carcinoma. What that is that there are glands, milk glands in the breast itself called lobules, and then there are milk ducts that bring the milk out to the nipple. So ductal carcinomas are when the cells along the ducts go haywire, their DNA is changed so that cancer grows within those ducts. That's the most common type of breast cancer. And the second most common type is something called lobular carcinoma, which is when the cells in the the glands get mutated and become cancerous. There's also an entity called ductal carcinoma in situ. That's a precancer that is also can go on to become ductal carcinoma, and so we need to worry about that as well. And that's when the cancer cells remain in the duct, and there's a little sort of shrink wrap around the duct that keeps it inside the duct. And when that happens, that's called ductal carcinoma in situ, which is considered a precancer that could advance to cancer if not taken care of. So these are the three most common entities that are cancer or precancer in the breast. Now I'd like to talk a little bit more about staging. And what staging is it describes how sort of much a cancer has spread and what and its associated prognosis. There's two main factors in staging. The first factor is called TNM staging. What that is that we divide how aggressive or advanced the cancer is by three factors. Tumor, which is typically defined by the size of the tumor, or the invasion of the tumor into different structures like the chest wall or the skin. So that's stage 0 or TIS, which is the in situ cancer, which is in the ducts, all the way up to T4C when it's gone through the skin and the chest wall, which makes it, of course, much more aggressive. Then there's something called nodal staging. Lymph nodes, as you can see over here in this picture, are small little filters that reside throughout your entire body. Typically, these filters filter out germs, but sometimes they can filter out cancers. The most well-known, I think, for most people are the lymph nodes in the neck. When you get a upper respiratory infection, you have a cough or a sore throat, you feel these lymph nodes in your neck get swollen, and they are tender typically. Well, there are lymph nodes in and around the breast that also can help with fighting off infection, but they can also filter out cancers. And when cancers get lodged in these lymph nodes, they can start to grow inside the lymph nodes, and that in turn tells us that the cancer is a little bit further on spread. And so that is part of the nodal staging. So N0 means that there's no nodes that are involved, all the way up to N3. Metastases are when the cancer spreads to other places. Unfortunately, breast cancer can spread to a lot of different places in the body, most commonly the bone, the lungs, and the brain. And sometimes we check those areas to make sure the cancer hasn't spread. Then we take this TNM staging along with other factors, which is on the next slide, and we give it stage grouping. Typically, we think of stage 1 through 4. Stage 0 is that pre-cancer ductal carcinoma in situ. That's stage 0. 1 through 4 is 1 is the earliest stage, 4 being metastatic disease or cancer that has spread outside the breast and lymph nodes. It used to be a little bit easier. They've changed the staging now, not just to look at TNM where it is, but also to look at some other factors, which I'll go through in the next slide. So when we do a biopsy or when we do a surgery, we can look at the tumor under a microscope. And the pathologist, who is the physician who looks under the microscope, can tell different things. They can tell what kind of cancer it is, ductal carcinoma, lobular carcinoma. They can give you a grade. The grade is usually 1 through 3, 1 being the most not so aggressive looking, 3 being the most aggressive looking. And so I don't really look at these too closely unless we're talking in a tumor board when we're all together, and then the pathologist will describe this grade. So this is a ductal carcinoma, and these ducts should just be one single blue dot all the way around, and you can see there's more than one piled up together, and that is a ductal carcinoma. Then we look at hormonal receptors, estrogen receptors, and progesterone receptors. They do special staining on the biopsy specimens, and you can see this one is ER positive or estrogen receptor positive and progesterone receptor negative. Also, there's something called HER2, which is another marker on the surface of the cells that is either positive or negative, and we can use different drugs to try to treat, giving good results. And finally, fairly new, but not that new, we can also run the specimen through a gene panel that can tell us a little bit more about how aggressive the cancer is. The most common one is called oncotype. And we take the TNM staging and these other factors here, and we can assign a stage. Used to be just TNM staging. Nowadays, we do TNM staging plus these factors to get stage 1 through 4. So now that we know a little bit more about breast cancer, I'd like to talk about the surgical treatment for breast cancer, just briefly because I'm not a surgeon, but I did want to introduce some of these concepts. So it used to be 40, 50 years ago, all women with breast cancer or pre-breast cancer would get a mastectomy or removal of the whole breast, and something called axillary lymph node dissection, where they would try to take out as many lymph nodes in the armpit area and up into the collarbone area as well. And then people started saying, hey, can we do something less? Can we do a smaller surgery? Can we save the breast and just do a lumpectomy? And they did some studies back in the 70s and 80s looking at this, and lo and behold, they found that they could if they did radiation afterwards. So that could replace mastectomy. And so lumpectomy is a standard of care, which is just removal of a small portion of the breast surrounding the tumor. Finally, as I said before, it used to be that we did axillary lymph node dissections where we would take many, many lymph nodes in the armpit area. Nowadays, we can do something called sentinel lymph node biopsy, which is we try to figure out what lymph node is the first lymph node that the cancer would go to, and that the surgeon will take that one lymph node out. The pathologist will look at it under the microscope then and there during surgery and try to figure out if there's cancer there. If there is, then they will do a lymph node dissection. If they don't see one, they don't see a lymph node that's involved, then we're finished. We can be pretty sure that there are no lymph nodes that are involved. So let's talk more about what I do. So radiation therapy, and this is a treatment machine similar to what we have. This is an older machine. I use the stock photo here, but this is the position typically we treat patients with breast cancer. And so there's a couple of different sort of scenarios in which we would offer radiation therapy. So after lumpectomy, as I said before, in order to get similar results to mastectomy, we offer whole breast radiation as part and parcel of something called breast conserving therapy, because we are allowing women to preserve their breast and get good cancer outcomes. There's a situation after a mastectomy. Typically, if there are no lymph nodes involved and it's an early stage cancer, we don't need radiation. But if the cancer is large, invading into different structures, or has gone to the lymph nodes, oftentimes we will offer something called post-mastectomy radiation to try to decrease the risk that the cancer comes back. And that includes radiation to the draining lymph node regions, especially if there is involvement of the lymph nodes. Finally, there's something called palliative radiotherapy, in which case, let's say there are symptoms and the cancer is spread. Oftentimes we don't feel like this is, if we don't feel like this is a curable cancer, we can still help with symptoms like pain and bleeding by offering and delivering radiation to those areas that are problematic. So going further into radiation therapy, as I said before, it's a series of X-ray treatments. This is actually one of our treatment rooms at Rush Copley. Basically, they're given on weekdays, Monday through Friday, once a day, typically 15 to 30 minutes a treatment. Historically, and with when we're treating lymph nodes, there are typically 25 to 33 total treatments, or 5 to 6.5 weeks. Within the last 10 years or so, we've been able to shrink down the number of treatments to 16 to 20 total treatments in 3 to 4 weeks by giving higher doses per day for early stage breast cancers when we're just treating the breast and not the lymph node regions. So why do we do radiation after a good surgery? Let's say your surgeon or your family member surgeon says, hey, we've gotten all the cancer out with clear margins, meaning there was space between where the cancer was removed, the knife edge, and the cancer itself. Well, we know that through all these studies that after a surgery, even if everything is good surgery, after a lumpectomy, that if we don't do radiation, whole breast radiation, chances are the cancer will come back more often than if we do radiation afterwards. So 2 to 3 times more often if we don't do radiation than if we do it. So we decrease the risk of the cancer coming back by 2 to 3 times. We also decrease the risk in the lymph nodes if we're treating the lymph nodes, if there's risk there. And because if we control the disease in the breast and the lymph nodes, there is some data that says that we decrease the chance that it spreads to the rest of the body later on. In the case of post-mastectomy radiation, after a mastectomy, if we deliver radiation for more aggressive disease, let's say larger tumor or positive lymph nodes, we have 2 or 3 really large studies have shown that we decrease the cancer decrease the cancer significantly and increase survival rates by approximately 10%. So how does radiation work? Well, radiation basically does damage to all cells, DNA, in the area that we're treating. So radiation comes in, breaks this DNA, and typically will cause what's called double strand breaks. What happens in normal cells is that they stop and they try to repair their DNA. Cancer cells, they don't want to do that because they want to keep on growing and growing and growing, using all their energy to grow. So when they go back and they try to build off the damaged blueprint, they die off. And so that's how we get our effect, is that when we treat the breast, the entire breast gets some damage to all the cells in the DNA. The normal breast repairs itself. The cancer cells that may be left behind don't. And so they die off at that way. When the normal breast doesn't quite repair that well, this is when we get side effects. So I'm going to go through some of the most common side effects first, and then some rare side effects from radiation. So the common side effects I've listed here are fatigue, skin reaction, sunburn, which a lot of people talk about, peeling, and breast swelling and tenderness. This can happen during and shortly after the radiation. The uncommon side effects, 10–15% maybe, there can be discoloration, significant scarring, or long-term swelling of the breast, typically cosmetic side effects. And very, very rare, there can be significant lung irritation or scarring, and there's an increased risk of heart disease, especially specifically if we're going to treat the left side. And I want you to pay attention to this because there are some techniques that I'm going to talk about later on that decreases those risks. Very rare rib fracture and a second cancer being caused by the radiation because of those DNA effects that I talked about before. If we do need to treat the lymph nodes, especially the lymph nodes in the collarbone area and the armpit area, we can get a risk of lymphedema, which is swelling of the arm. And we can also, because the base of the neck is treated for some lymph nodes that are there, there can be a little bit of throat irritation as well. If after a mastectomy, implant reconstruction is considered, there can be a risk of significant scarring around that implant, even if the implant is put in after radiation is done. I wanted to talk briefly about the radiation treatment process, and step you through what we do. So first off, typically a consultation with myself or one of my colleagues is requested by a surgeon or a medical oncologist. We'll see you and we'll do a consultation and we'll review your case and basically educate you on what we're going to be doing throughout the course of treatment. Then we bring you back for what's called I like to call it a radiation treatment planning session. It's called a simulation, where we put you in that treatment position and we do a scan through your from the chin down to the waist through the area that we're going to treat, so that I can do some designing specifically for your body. That session takes about 45 minutes to an hour and a half. Then I sit down with my treatment planners and do some computer work and plan out and design the radiation specifically for a patient's body. And then we do a verification, which is checking the setup before we start our treatment. Sometimes that's done on the same day. After the treatments are over, we will schedule follow-up according to how often other physicians will be seeing the patient, or a standard sort of course of follow-up guidelines that we have for our practice. Finally, I want to talk about radiation techniques that we use now to try to reduce side effects without compromising the effectiveness of our treatment. So we'll talk about the prone position. Typically, we have patients on their back with both arms above their head, but this is a different positioning where you're on your chest and belly. Then I'll go to deep inspiratory breath hold. Basically, it's a very simple thought process where we have you hold your breath while we treat you, and I'll tell you why that works well. There's something called accelerated partial breast irradiation that just treats a little portion of the breast. There's another form of radiation called proton therapy. And finally, I list this here, but there's a possibility for, hey, maybe we don't need radiation. I'll tell you why that could be the case. But that is typically not the standard recommendation, but there are some instances that we can omit radiation. So this is a picture of our prone breast board setup. What happens here is that we have you lay on your belly. There's a little donut here for your head, and the breast hangs down in this area instead of with the patient in the treatment position supine, which is on the back. And what this does is it helps pull the breast away from the chest. So this is a CT scan. This is the spine. Here are the lungs here, and here's the breast that is hanging down into that hole in the board. This is the opposite breast over here. And because we're having the breast hang down, sort of like a mammogram or an MRI of the breast, this brings the breast tissue away from that chest wall. And so we can spare a little bit of the lung more and a little bit of the heart as well. And it flattens out the breast a little bit, makes it thinner, and that can also help with the radiation delivery being a little bit more smooth through the breast. So here's that prone position here with the breast hanging down. This is a different board. This is not our board, but I just use this to illustrate that position. So deep inspiratory breath hold, just a complicated term for we'll have you hold your breath while we treat you. What this does is it brings the heart, if we're treating the left side, away from the back of the chest and downwards as well. So I'll go through this picture. This is an infrared camera that is placed at the on the machine that can sense this block, this plastic block, which is placed right at the sort of where your abdomen and chest meet, close to the bottom of the breastbone. And so when you take a deep breath in, this block will move upwards because you're inhaling all that air. And this is a normal breath sort of diagram here. When one person takes a deep breath, this line will move up into this area, and then that expands the lungs, pulls the heart away, and that's how we treat the patient. And so this is what this does for us. This is, again, a CT scan with the patient in the supine position, which is on their back. This is where the surgery was done. As you can see, there's some metallic clips that show up white. These are the ribs here. The black is air in the lungs, and this is the heart. And so this is without deep inspiratory breath hold. Look how close, if we had to treat the radiation through this area to try to encompass the whole entire breast, look at how close it comes to the heart. And this is sort of what we call a beam's eye view. If we're looking at what we're treating, this area is the radiation area. Everything else is blocked out. This area is where the tumor was. Here's the rib cage area. This purple shape corresponds to the heart. And so you can see the little bit of the heart is in that area that is getting radiation. In this case, we have the patient take a deep breath. And as you can see, the heart's kind of disappeared in this slice. It really hasn't disappeared. It's just been pulled downwards and backwards. And so in this slice, there is no heart. This is one of the larger blood vessels that are coming off the heart. And so the heart is moved downwards here and backwards a little bit. So posterior or back towards the spine. And so then we can kind of put a little block in here, and all we are is treating the breast, little rind of lung, but the heart is out of the way. And so that is, it's been shown to be very effective. Used to be that we didn't pay attention to where the heart was, 20, 25 years ago, and there have been studies that have shown that there was an increased risk of heart disease. Nowadays, with these techniques, I believe that if we look further on down the road, 10, 15 years from now, that the risk of heart disease is going to be minimized by using these techniques. Accelerated partial breast irradiation. This used to be done years ago. We used to do this quite often, typically with brachytherapy, which is internal radiation, where the surgeon would place a device called a brachytherapy catheter inside the area that we wanted to treat. And we would deliver radiation internally with twice daily treatments over 5 days. That can also be done with external beam. The thought was we don't need to treat the whole entire breast because when the cancer comes back, it usually comes back right around where the breast cavity, breast lump was removed. However, a large US study has recently shown this to be a little bit less effective than whole breast irradiation. Plus, one of the benefits was it was a shorter course of treatment, but nowadays we can do fairly short courses of treatment with whole breast radiation as well. So it's kind of fallen out of favor to do this brachytherapy because of the invasive procedure that needs to be done to insert these catheters. However, there are new once daily schedules that have been tested, and there's one schedule from Florence, Italy, that is 5 days worth of treatment. I think all radiation oncologists in the US are looking at this data, and we're staying tuned to see if this is going to be okay to use in the States. But right now, that is not the standard of care. Proton therapy is it's another kind of radiation where a particle called a proton is used. And we have one of the only centers that offers proton therapy in the Midwest down the street in Warrenville. Theoretically, it's a better particle. It goes in and it stops on a dime. And so it could be better at sparing internal structures. However, there are studies that have shown maybe there's more side effects, and we don't know if it's any better clinically. So the clinical studies are ongoing. They are running clinical trials out of the Proton Center, and it is an expensive therapy, so much more expensive than photon therapy or X-ray radiation, which is what we do. And finally, omission of radiation. There are, first off, all women have a decreased risk of recurrence when we do radiation after a lumpectomy. However, there are some patients that the rates of recurrence are so low already without radiation that even if we do radiation afterwards, we may drop their recurrence rate from maybe 10% down to 5%. And that extra 5% may or may not be meaningful or useful because, hey, some patients have other illnesses in their health that could unfortunately take their life even faster than the cancer can. So sometimes we say, hey, if the cancer is very well behaved, the patient has a lot of comorbid conditions, meaning they have other illnesses in their health that are pretty bad, maybe it's not worth doing radiation. So that's a conversation for a radiation oncologist and the patient to have to say, okay, well, maybe it's reasonable to not do radiation because the benefit is so small, even though there is a benefit. And with that, I'd be happy to take questions.